Call upon Dr. MATHEN to talk about Femto and Zepto capsulorhexis, their advantages and limitations.
So good morning, ladies and gentlemen. Can I have a show of hands? How many of you are using Femto? So very few, but there are very few people who are using it. But then somehow it's not very popular because of the cost, but the cost is coming down. And Zepto also we need to talk because that is also available. Because any automated way of doing a capsulorhexis can make a perfect circle. So it's debatable whether you need a perfect circle or a near perfect circle. But we know that your optic is definitely circular. So if you have a near perfect circular capsulotomy, I can call it a capsulotomy, and then you can have a perfect overlap of the IOL and a perfect centration if done well. So no financial interest in this talk, although I'll be talking on the Alcon machine on femtosecond laser capsulotomy. So just to show you, under when the patient is under the machine, this is what you will be seeing. And once we bring down the PI close to the patient's eye, we can note that, see, this is how it goes for an applanation. This is one which applanates. And once it is, suction is applied, you can have the rhexis margin, you can measure. Now I'm placing it at 4.9, you can have it 5, 5.1, 5.2, whichever. And then the incisions and the nucleotomy and all those can be adjusted. If we are doing it under the Varion, which is the image-guided technology, it will automatically center it. Once we have captured the limbal architecture and the picture at the Varion level, and you transfer it to the machine, and it gets automatically integrated, and you take a picture on the table by the Femto, it automatically takes the picture and centers the capsulotomy margin. And this is how a perfectly flat dock with the eye not tilted, it will look like this. It will be a flat one, otherwise you'll see it is curved. And then you can mark onto the incision and finally fire. So when you fire, the capsulotomy is done first. You can see that it happens from below up. So if it is flat, you'll see it form, and it in this platform it takes a while, whereas Catalyst and other ones, they take very few seconds. But then anyway, mostly nowadays with the improved software, we are getting mostly free floating capsulotomies. Once you finish this and take them onto the table, the capsule can be just taken out. But there are limitations for this also, and we will come to that. So this is how it will look. So after the capsulotomy, there will be a nucleotomy also done. So this will generate gas or air inside, and you will lose this good red glow, which you're seeing mostly in your regular cases when you're doing a capsulorhexis. So the identification of the rhexis margin, even if you have a lumera, here there is a lumera and you have good red glow, still you may find it a little difficult to identify the margins. So I take it with very great caution and move it along in such a way that it moves as though you're doing a rhexis. But because sometimes there may be skip areas, maybe because of the level, maybe because it didn't hit fully. So such areas should be included. We'll come to that. And once it is done, it's a very gratifying look of the rhexis covering the IOL so nicely, and the IOL being centered and the rhexis being very much centered. But the price you pay for this is a little too much, I know that. But then again, technology will evolve and the prices may come down. But this is what you get right now from the machine. So one application for this is in mature cataracts, because sometimes it may cut through even small time fibrosis, sometimes it will cut partially, sometimes it may cut fully also. Here the problem here is they may not be able to focus at the blinking red light which they're supposed to look at straight. So the docking may not be that very perfect in this kind of a total cataract and mature cataracts. So sometimes you need them to be blocked because of language issues, patients cannot hear, they cannot cooperate at all. Then again, you should not be having too much of chemosis, and the eyeball has to be centered. You can use some forceps and some instrument also to guide the globe till it gets docked straight. But the main problem in here, this one, hypermature one, is if the area which gets completely cut first will let out the fluid cortex which is there. So sometimes that will come in the way of the laser, and that will also again change the level of the capsule. So you may get incomplete capsulotomies in these kind of hypermature cataracts where you can have this. So once I have done this, you can start firing, and if you see, notice carefully, look at this point where it starts and see the gush of this one coming out, and then it blocks the laser in that area. You don't get it cut because it doesn't cross through opaque medium. It doesn't cross through gross arcus, mature cataract it doesn't pierce, but then still whatever available you'll get it, but then the level again changes, the cataract capsule, so you may get it very much incomplete. So once I have a mature cataract or a hypermature cataract or intumescent cataract done, I always put stain. So once I stain, I know where the anterior capsule is and whether it is moving freely or there are attachments. So many times there will be attachments. Here if you notice, it is almost full. But then there is a point where this point where there is a tag here. This is a small tag. So this small tag, these areas where this is not like your regular capsulorhexis. There are multiple fine spots of laser which are applied, and there can be laser spots which are there on the intact capsule. So those are weak areas. So if they are not taken care of, or they are not included within the rhexis, during chopping maneuvers you can have them extend onto the periphery. Here again there is a definite bridge. Look at this. This part is definitely there is a bridge. So identify that by staining, and then hold it with the forceps and include that area within the rhexis. Go a little out rather than being inside. So that those areas which are skipped will also be included in this. You may not get it fully round there, you can see it, but then it will not be a weak area. That is what is most crucial about this one. One of the greatest uses I find in cataract surgery are in only two cases. That is, one is subluxated cataract. Subluxated cataract without a capsulorhexis, it is as though you cannot use your capsular CTR or a CT ring, even a CT ring. Many times you even have to abandon even phaco without using the capsule stabilizing devices. So if you can do a pucker rhexis and a rhexis which is centered to the lens, here you can notice, initially when I showed you, this is the picture after this one. I just wanted to show you where the area of subluxation is. So the location of the rhexis can be moved away from the area of subluxation. That is the good thing about Femto, so that you can center it on the lens rather than centering it to the pupil. Or here you can see I can move this away from the area of zonular dialysis and have a completely intact capsular rhexis. Once you have that rhexis, then placing in a capsule tension ring, doing other maneuvers inside the bag is all very easy and safe. So that is one thing. In small pupil, here comes the limitation. So it cannot pierce iris, that's for sure. So if you have less than 3, there are people who show that you can put in a ring, take out visco or retain visco suture, bring the patient back. Or there are now machines where you can do it in the same room, but then still you open up the globe and then bring something in. You can still do it sterile, but then still I don't recommend that. I don't like it. So small pupil less than 3.8 or 4 millimeters, I do not do. But this is one just to show that this one actually dilated little more on the table with some phenocaine, but then it was less than 4 millimeters to do. So it was we did a 3.8 and actually struggled with the phaco and all this. So at this point itself, I should have enlarged the pupil with hooks or rings and then enlarged the rhexis and continued. So now wisdom comes on. I increase the pupil size and I finish somehow. So I inject the eye hole inside, and you can see the eye hole. I am letting the eye hole open within that rhexis. It is quite risky, just to show that it doesn't open up that very easily. It is not as weak as it has been told. It is quite a strong rhexis margin still. Now you can notice that it is very small. So I take the liberty of having the initial rhexis margin as the guide and do as round a possible rhexis with my hands for this patient. This was the original one, this was the expanded one. But then I don't think it gives you any advantage for doing a small one, and then only for maybe a patient satisfaction part if patient is insisting on a laser, and some people are really happy if laser is done on them. I could do a rexus, so I was so happy that it is the mindset of people. So why not make them happy and do your job well? So I just don't refuse if there is a minimal possibility of doing a 4 millimeter up to a 4 millimeter rexus. Now sometimes this is a rexus, intact rexus margin. You can notice very clearly here rexus margin is intact. IOL injection sometimes, especially when these lenses, when they are over, when this injector tip overlaps over the optic, it sometimes gets pushed in, propelled like a rocket inside, and instead of the capsule, posterior capsule breaking, here the anterior capsule breaks. See this anterior capsule? This anterior capsule breaks. So remember that the manual rexus would be definitely any time stronger than this, and deal with these kind of rexus little carefully and gently. And the cost factor is quite high because we need to use a patient interface, which is a disposable one, comes at a very high price, which the patient has to pay. But more and more patients are taking it because they want to adopt new technology. So coming to Zepto, so Zepto, who all are using Zepto? So last week in ASCRS, they have launched a new platform which is connected to the machine itself. And it can do the suction and all can be connected to the machine itself without having a separate unit. And so it is also developing. So we used it for a demo purpose. This is an instrument which has the tip, which has a nitinol ring, which is surrounded by a soft silicone cup like this. And the under surface will look like an inverted frying pan, and which has suction tubes inside. And when you place this inside the eye, you can center it, and then you can apply suction, which is very minimal. It doesn't apply too much of suction, but then, and it can be folded like this by pushing the tip forwards. It can bend the nitinol ring, and it goes through a 2.8 incision and even a 2.2, and then it will, when you retract this central one, it comes back. And once you release this, it becomes round, and with the centration, which you see with the Purkinje images, you can center it, and then apply the foot pedal. You can have suction on, and here this is by electric pulses. A train of low energy electric pulses will deliver pulsed energy. In that there is some water molecules undergoing phase transition and then creating this cutting effect, and it instantaneously cuts and gives you a perfect round capsulotomy. Again, this is the cost factor is also there, but then it need not accompany the whole Femto machine. So this is a standalone one, and it is cheaper for the patient. But then again, it comes on a cost. So the point is that it can be marketed as an automated one, but it cannot be called a laser because it is not laser. So maybe marketing part, people call it laser, but then actually it is not laser. And ethically, we cannot be telling the patient that it is laser. So although this is so please look at this, is the same case. So at the beginning, you can see the margin of the opening. It's completely intact, especially here. Please focus here. It's completely intact. I do a hydrodissection, a regular hydrodissection. It goes to the opposite side, stop, I just tumble the lens a little bit. And now please note here, this point, can you see here, this line and this line, it has given way. So this may also happen. So in automated ones, all these, please be careful with the maneuvers which you do, especially in the initial cases. If you have, sometimes it can give way like this, and so be careful. I'm not scaring off people that all the rexus margins with automated machines will break or anything like that, but then have this in your mind when you are doing with automated machines.